I'm going to talk very briefly about ongoing pediatric sedation, and if you've been to my house recently, you'll know that there's only one possible theme that this talk could have, because we are currently completely obsessed with Bluey in the region of watching about 7 episodes a day. Thankfully, they're only 6 minutes long, and they are very entertaining. So something that's come up a lot in coffee and cases and post-mission discussions is, once we've done an RSI for our pediatric patients, how do we keep them asleep? And Sleepy Time is an episode of Bluey in which Bingo, this is Bingo in case you don't know, Bluey's little sister, is determined to remain in her own bed all night. It's not quite what happens, but she certainly wakes up there in the morning, and that's what we want. We want our children that we have intubated to remain in the bed that we've put them in for the duration of the transport. So I've got 3 options for you. Option number 1, I like to liken to Bluey's dad, Bandit. And option number 1 is probably what you've already been doing, which is to use your pre-drawn syringes that are in your pouch and just continue to give boluses. And the reason that this is like Bandit is because, honestly, it's a little bit basic. Bandit is a wonderful character, but he is extremely rough and ready, but when it comes to it, he gets the job done. The challenges with using your pre-drawn for boluses for kids for ongoing sedation is that it's a real pain along the way if you need to do other stuff. For longer transfers, it's going to be a real nightmare for you to keep giving little boluses to keep the child asleep. Sometimes you're waiting to see if they're waking up a bit before you're going to do something, and that's not ideal, particularly for children with head injuries, which is one of the commonest causes of major trauma. But at least you know where you are and what you've given, and it's easy enough to hand over at the end of the day when you arrive there, as long as you haven't run out of a syringe. That'd be a really long job. So if that's what you're doing, that's fine. It does the job, but not a lot of finesse involved there. Option number 2. If you imagine that you're on a mission where there is a critically injured child, and then you decide to add an actual preschooler to the scene that you have to control and manage, that is option 2 for you. I'm going to liken it to Bingo, because Bingo is small and extremely needy. All right, so this is the NETS clinical calculator. If you want to find it, you can Google NETS clinical calculator, or you can go to the NETS website. It comes up in the first table. It says driving directions. Don't know why that would be the first thing you need. And then NETS clinical calculator. And when you open it, you get this. There's a whole load of choices, and basically what you want is either this one or this one. If you select one of those, you then get this little box at the bottom that gives you an option of how you're going to calculate the child's age, either by putting in their date of birth, if you've got it, their age in years, and whichever of those 2 you put in, it will offer you a little weight in that box. It says an estimated, I've put in 1 year, it says use an estimated weight for 11 kilograms. If you click that button, it will pop 11 kilograms in there, and then you hit calculate. And you get an absolute child-appropriate word full of drug options. In the section marked continuous infusions, you've got an option for fentanyl, ketamine, and midazolam. And if you look at what they're using in terms of the drug and the content, these are the ones that you carry in your red pouch, your non-pre-drawn versions. So we carry the fentanyl 500 mics in 10, we carry ketamine 200 milligrams in 2, and we carry midazolam 15 in 3, so that's 5 in 1. They're the same concentration. Now, we'll come back to this slide in a second, but essentially how this works and how pediatric sedation works in the vast majority of pediatric intensive care units is by using a variable solution. So you make up the concentration according to the weight of the child, and then you run it at a standardized rate. As you can see, this involves a lot of maths, which is why I say it is like bringing a toddler to your already quite stressful scene and adding Bingo in there that you also have to manage. Bingo's going to be running around, asking you questions, trying to mess with your mind, okay? And like any toddler, if you're going to use this, it needs careful handling. But the upside is when you turn up at the hospital and you say, I've used the NETS calculator and I've made it up to the required solutions, you're going to get a lovely empathic response, because that is what the children's hospitals are expecting you to do. Okay, it's worth knowing that the calculator itself doesn't work particularly well on the phone because there's so much data in there. You can do it, but it's a little bit clunky. So the best way, if you decide to use this, is to get someone to print it before you go, or use the iPad if you can. And you are going to have to do all those maths under pressure. So there's a massive risk of you causing some drug errors. But as I said, the people at the other end are going to know exactly what you've done, exactly why you've done it, if you've got it right, and they're going to be massively impressed with you. Option number 3. If you are a Bluey aficionado, you now get to meet my absolute favourite character, Unicourse, described in Bluey as the most annoying puppet in the world. So this is going to completely disrupt the hospital system, but actually, just like a puppet, it's super simple. You're going to use what is in your hand, which is your pre-drawn, and then you're going to use what I have created for you, which is not going to be this. Don't take a photo of this because this is not the final version. But this is the maths that I have done for our pre-drawns based on the weights that are in the pediatric drug dose guide. And I've calculated using the NETS infusion rates, what you can run your pre-drawn at to give the equivalent infusions. And when you eventually get a copy of this, which will probably be in the reprinted next version of the pediatric drug dose guide, I'm going to take out the maths columns. So you'll just have something that looks like this for the age, the lower rate of the infusion and the upper rate. And crucially, it's going to tell you what those ranges equate to. So that when you turn up and you say, oh, this 4-year-old, the midazolam's running at 1.08 mils per hour, which is equivalent to 1 microgram per kilogram per minute, then you're speaking their language. Because what we have, which is the inverse of what the Children's Hospital have, is a standardized solution that we're going to have to run at a variable rate in order to get that. And that's where all the maths comes in. So essentially, using our pre-drawns like this, it's basically a puppet. We're just going to take our hand and make it work. But it's going to work. Don't have to do the maths on scene because I've already done it for you. Just run it between some dose between those parameters that I'm going to give you. Hopefully, if you've got the wherewithal to do it as a multiple of that of the first column number, so you know if you're doubling it or you're doing 3 times it, then you know it's 1 or 2 or 3 micrograms per kilogram per minute. But what you also need to know is at the other end, there's a reasonable chance of butting heads. Because when you turn up, they're going to be absolutely mind blown by what you've done here. Why on earth are you running this mad infusion concentration at this completely inexplicable rate? Which allows you to then use Unicourse's famous catchphrase, which is, and why should I go? If you haven't watched the Unicourse episode, honestly, it's brilliant. It's mostly brilliant because my child, who many of you know has a problem with biting other children in anger, he's perfected his impression of Unicourse, who, when asked by Bluey, what's your favourite food, jams his face up against Bluey and says, children. So my child can do an amazing Unicourse impression. You'll want to say this, but realistically, you're going to have to walk them through how you've got to the rate and the infusion rate that you've got to, which isn't going to be more than just pulling it out and saying, this is what our protocol says. If you say to them, because we have a standardized solution, we're running at a variable rate, but this is equivalent to this number of micrograms per kilogram per minute. And there is complexity there because for fentanyl, it's going to be micrograms per kilogram per minute micrograms per kilogram per hour is what the NETS calculator uses. And then midazolam is micrograms per kilogram per minute and ketamine is milligrams per kilogram per minute is how they're all phrased in the NETS calculator, just to really mess with you. So I had to do a lot of maths, and Sarah Aldington has kindly checked this with me and picked up at least one error that I made. But I think this is going to be a lot simpler for those massively complex jobs. So I wanted to make sure that when these numbers come out, you have some understanding about what it is that you're doing when you're using your pre-drawn as an infusion and how that's going to affect your handover at the other end. But I think it's probably going to make more sense to offload the maths and the cognitive bandwidth that you're going to require to do those calculations. If you still want to draw up your NETS infusions on scene, the best of luck to you. I respect you greatly and how you have much more brain power than me. So in summary, you've got 3 options. You can continue to do your pre-drawn boluses, use your bandit method, totally fine, just a bit basic. You can introduce your crazy toddler to go running around your ankles and like asking you why every 5 seconds by using the NETS calculator, or you can bring in Unicourse and use your pre-drawn at an infusion rate that I'm going to give you. Those are the 3 options I have, and hopefully that's going to help keep children asleep on the way to hospital and give us better control of the situation. And on that note, I will ask you if you have any questions, and we can talk more about ongoing sedation. Yes, is it a question about Bluey or is it a question about sedation?
It's a question about sedation.
Good, okay.
Bluey experience is limited.
You should go home and watch Bluey immediately.
When you arrive and so on, they're going to obviously switch to their stuff.
Yeah.
how much of a concern is the concentration that's in our vessels, in the cannula, in the central line, whatever, when they then start running their infusions?
I think that we're probably going to be running them at higher rates than they are, so it's going to go a bit more slowly. So even though they're potentially going to get it a little bit more concentrated, but they tend to run between 1 and 2 mils an hour for the non-standardized solutions that they come up with. So that's worth considering. And I think if you just appreciate that at the end of the job, you're going to have to sit with them and say, this is what is in this syringe, and running it at this rate is equivalent to that. And they are not going to continue to run your sedation. They're going to be completely flummoxed. They probably are going to be in the space you would be in if you were trying to do the maths on scene, and they're probably going to take usually at least 2 nurses to go away and do the calculation and have someone sign off on it before you go. But that's a good consideration to make sure that if there's an extra line, they've got an option or to draw back and flush. But usually at the children's hospitals anyway, they're at least taking some bloods when you arrive and doing some of the alternative access options, so they can just put it through a new line if they've got one.
Sorry, on the same note, this is just for sedatives, not pressors and so on.
Yeah, just for sedatives. Yeah. They do the NETS calculator for pressors. It's all in there, all the infusion stuff. And I would say I'm not going to do that maths, because I think if you are going to start pressors, pretty unusual for a pre-hospital scene anyway. If you're doing a NETS transfer, you've usually got the time in the hospital to make sure that's right before you go, and I would probably do that. And if you're doing a transfer on behalf of NETS because they've asked for a team for us, then I would definitely err towards using their infusions, because it's going to be simpler all around.
There was a comment from online as well, just as a thought, because we're going to be using very low infusion rates in small children, be aware that you need to prime lines, cannulas, bungs, etc. will give us more bolus, otherwise it might take a long time to reach the child.
Yeah. The other issue we've got is that and the reason that I can't give you any maths at the moment is that the way that NETS dose their infusion of ketamine is very low at the upper end. So I've had to try to find some research that supports us giving a sensible dose. Like the best way to get an idea for whether it's a reasonable amount or not, let's just go back, is to look at what they say for a 12-year-old, and I kind of go, does that sound like a reasonable dose that I'd give an adult? Because many 12-year-olds are almost adult size. And if you're running your midazolam infusion for an adult, somewhere between 2.5 and 15 mils, I'm like, yeah, that's a ballpark, approximately right number. So that's a good check as well for even if you are using this, if somehow you've gotten a bit confused along the way. If you're in, good rule for any pediatric drug dosing is if it's more than you'd give an adult, it's probably wrong. Cool. Any more questions?
I think that priming is...
Thanks. I think the priming things it's something to be sort of wary of, where intuitively we do it with our central lines in adults, don't we? We go, it's about 0.4, 0.6, plus a bit of fudge for the bung. And
if you look at the NETS infusions for this 1-year-old, you're going to have exactly the same issue running at 1 mil an hour of how long it's going to take to get to the end of that line. So it's going to be whichever method you use, you need to bear that in mind.
Yeah, that's good. The other thing to bear in mind, and Carol's alluded to this just online as well, is our syringe drivers are fairly rudimentary, as you know, the Nickies. They work on a worm drive mechanism. And in fact, what you get with that is not a smooth delivery rate, but a series of micro boluses. And that's probably exacerbated at very, very low running rates. And the occlusion alarms similarly don't, might take a while to build up. So it might take you some time before you realise, in fact, that you've blown your drip when it's running very, very low rates like that. So just a couple of practicalities to think about. And it might, it may be that we discuss not so much for using our pre-drawns, but some of the other infusions, better off sort of having a lower concentration and running them at a slightly higher rate, just so we know that they're delivering properly.
Yeah. We can certainly look into it. And we haven't really, it's been something we just generally have managed with boluses. I know people have done other random infusion techniques in the past, but I think there's enough variability and enough pediatric patients now that it's worth us thinking about how we approach this and doing the maths for our pre-drawns and seeing how it works. And if it's not working, then we can consider formalizing something as an alternative.